Okay, hey guys, good morning. We're going to go ahead and get started here because we've got some content to crank through for you with um, screening guidelines. So I'm pretty excited to go over some of this stuff today. If um, my audio starts to go in and out or there's any issues, let me know in the comments. I try to monitor them, but we're asking my computer to do a lot right now because I'm live on YouTube and on Facebook and on Instagram and on Zoom. So we're on a lot of different platforms here. Um, but I do want to just go ahead and get started. I need to minimize. I don't want to see myself while I lecture for you guys because hopefully maybe that will help with everything a little bit. Okay. Well, welcome in, guys. My name's Annalise Caffrey. I am a DNP FNP. I got my doctorate at the University of Tennessee. If anyone out there is joining from Tennessee, go Vols. So graduated that as a family nurse practitioner. My background is specifically really in preventative care, like we're discussing today, screening guidelines, but then also going into kind of specific care with like diabetes, hypertension, geriatric care. I minored in gerontology, so that is very near and dear to my heart. I gave a webinar earlier this week on geriatrics, and that is uploaded onto our Facebook page. If you weren't able to make it, you can watch the recording of that. But screening guidelines, especially, very important topic that we discuss, and we need to discuss it every single time we're seeing every single patient. That's why it's kind of one of those catch-all topics, and why I'm excited to talk about it is because screening guidelines carries over to everything we do as an APRN. It is something that I go over every single time. So I may be seeing a 5-year-old, I'm looking at their vaccines and screenings for that. I may be seeing a 65-year-old, I'm looking at their screenings for that. Preventative health and health maintenance is something that is very important. These annual exams, that's a key time to discuss them, but really you want to do it every single time. You're looking at their chart, you're making sure they're up to date on things that we don't need to order anything because this is preventative medicine. It's a very upstream approach, which I think is something in the United States we're really trying to push recently. If you think about it, and I've done a lot of global health stuff. I did some medicine out in the Czech Republic, in Germany, in Poland. I did some stuff in England. I did a lot of stuff down in Belize and Central America. And so you get to see a lot of different countries, guidelines, what they do, how they treat, how they take care of patients, how they practice medicine, and pros and cons for everyone. I will be the first to say, I do not think there's a perfect medical system out there in any country. If you think your country's the one that has a perfect medical system, let me know. I'd love to come practice in it for a little bit. But there are things I like and dislike in every single country I've been to. It's one of the amazing things about how diverse the world is, really. And so with screening guidelines, I think really the world in general, especially here in the United States, we've taken too much of a secondary and tertiary look at things where it's like, okay, they've had a heart attack. What can we do now to treat them? And we want to start looking at what we can do to catch this stuff earlier on. So prevent it with, exercise, strength training, eating healthy, teaching to never start smoking, but then also secondary things that we can look at to kind of catch things earlier, which we're going to talk a lot about some secondary screening guidelines today. We won't be able to cover all of them, but I spent all of yesterday writing a lecture for you guys that I'm going to be recording soon that goes into all the health maintenance things that we teach that are recommended. So that's going to be a lot more in depth, and we can look at that one together in a couple months, hopefully when that launches. So real quick before we get too in depth into it, let's take a look at our disclosures. I have to put this one on. Archer Review is accredited. So that means you guys can get a continuing education credit for being here today. This webinar is worth 1 education credit. If you signed up through Zoom, that's going to be how you get the credit. For those of you on YouTube, on Instagram, on Facebook, you can't get the credit for attending through those because we don't really have a way to track if you're there and names and emails to send out. But if you go to the archerreview.com, if you go to archerreview.com, you can see all of our FNP webinars. We give a few a week usually, and they all qualify for free continuing education credits. So if you sign up on there and you join through Zoom, after you stay for the webinar for that full hour, you'll get an email with that certificate for you. So join for future ones. Those of you that are here in Zoom with me, here for that credit, stick with me throughout the whole time. If you leave early, you won't get the credit. Um, Learning objectives, just real quickly to touch on this. Some of the big things we want to go over today, we wanted to touch on those age and risk-based recommendations, especially those preventative screenings. So preventative screenings, and then cancer is going to be a big one because we know that cancer is on the rise really worldwide. And so we want to do what we can to catch cancer earlier on. If you catch it at stage 1 compared to stage 4, we can really affect quality of life and longevity of life, how treatable something is. We want to differentiate between screenings and surveillance strategies. And then we also, lastly, we want to apply evidence-based screening recommendations to some case scenarios. So we're going to have some practice questions, some pop quizzes, and we're going to see how comfortable you guys feel in this stuff. So to get us started, we're going to use Slido. If any of you guys have joined my webinars or other people's webinars before, this is something we're really pushing right now, is using Slido, just because it's the easiest way for me to see everyone's answers, whether you're on YouTube, Facebook, Instagram, TikTok, Zoom. So come over here. If you scan this QR code, this will take you right to it. If you're already on your phone though, and you're just going to be hopping back and forth between, your Instagram and this, just type in, if you go to slido.com and type in hashtag screening, that is going to get you into our poll. So I will give people just a few minutes to get in and answer our very first question. Where are you joining from? Just a little warm-up question. I want to see where people are coming from, so that I can get a better idea of who we have here. We have someone joining from Utah. That's where I am. I'm in Utah right now. I'm like maybe 40 minutes south of Salt Lake City. Texas, Connecticut, Florida. The United States are really representing today. Oh, another Texas. Oh, we've got Arizona. Okay, we've got a good little mix today, guys. Some people in some really hot states and some people in some humid states. I don't know if Connecticut, if they've warmed up yet. I don't know what your guys' weather is like. I'm gonna have to look that up after. Colorado, my neighboring state. Canada, we've got a Canadian in the group. Welcome, welcome, everyone. I am very happy to have everyone here. Okay, hopping over to the next one, I want to know where you guys are at in your journey. So this just helps me kind of, both for this webinar and future webinars, kind of guide what I'm teaching and how in depth we're going in things. Are you students? You're in your first semester of APRN school, you're just applying. Have you graduated? You're already practicing, you're taking your boards, you're retaking your boards. I want to know where you guys are at. Waiting for a job? Congratulations on passing your boards. That is super, super exciting. Email me when you get a job. I'll be really excited to celebrate you. That getting up. I remember like my first APRN job, even though I worked as a nurse before, it felt like my first like big kid job. Retaking the ANCC, I say it every single time. We've got a couple people retaking their boards. Nothing to be embarrassed about. It's not going to stop you from being a good provider. I always tell people the boards are a test, and it is meant to be a test. It requires test taking skills. It requires certain information you study for. Practicing in a clinic setting, totally different. It is not the same. Obviously, we take the boards because we want to be safe clinicians, but I personally do not think it is indicative of all about what kind of provider you're going to be. And so it's just a little hurdle in this step. You're going to pass and you're going to be a great provider, and people are going to be very lucky to see you. So we're happy to have you. A lot of students, 3 courses away from graduations. Congratulations, guys. That's big news. Okay. One last poll before we get started. I just want to know how confident people are on this subject matter, because that really does kind of give me a good layout to see how people are feeling. There's a lot of screening guidelines to know, and I think that's what can feel overwhelming sometimes, is it's like, okay, now I have to memorize colon cancer and breast cancer and cervical cancer, and also then just what are the recommendations for exercise. So that can start to feel overwhelming. Today we'll look mostly at the secondary screenings, and hopefully by the end you guys are just like, yeah, this is second nature for me. Okay, that is great. Awesome job, guys. Okay, moving on. So the first thing I want to touch on here is about where we find our guidelines and how we know they're evidence-based. Because of course, if we're recommending something to our patients, we want it to be based in evidence. That's really important. It's important that the information our patients are getting is not just Annie's opinion or Nick's opinion. It is what is the most evidence-based, up-to-date information that we have. And so with that, we're really lucky because we live in a day and age where we actually in the United States have a task force specifically for this. So we have a trustworthy place to start. It's called USPSTF, or the US Preventative Services Task Force. So they state that their goal really is to work to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease and prolong life. So really what they do is they look at all the research that's come out. So let's say someone out there's done research and they say, yeah, like we should be cleaning our ears with Q-tips. They're going to look at that evidence. This is just a funny example, guys. Okay, just so you know, they're going to look at all the evidence, pull all of it together, and they're going to make a recommendation that they grade. So they grade the strength of recommendations A, B, C, or D. We're mainly going to be focusing on A and B today because those are the strongest ones. Those are recommendations that there is a moderate to high likelihood that there is a really good benefit to our patient. So a substantial benefit, and we want to be doing these. They also have a strength of recommendation that technically, I guess, isn't considered a strength. It's an I, which means, there's not enough research to support it. So I'm not going to say D, don't do it. Like D's when they're saying like, we actually recommend against doing something. I's more saying jury's still out. We don't know, not enough research yet. So we're mostly going to be looking at A and B, but they really make a ton of recommendations. And I forgot I was going to add this slide for you guys. I added it in my other lecture, but let me just show you guys here. There is an app for this, for the United States Preventative Services Task Force. It is the thing that I have on my phone that I use the most. So whether you're on an Apple product or on a Android product, so Google Play and Apple both have this to install on your phones. I have it. I keep a folder. I was talking about this in my geriatric webinar. I keep a folder on my phone that literally says, it is my medical folder. See, so I've got all my apps in it. I have my stethoscope connects to an app. I have the CDC's vaccine schedule. I have up to date. I have Hippocrates. I have my cardiovascular risk screening, and I have this US Preventative Task Force app. It's my number one app that I use. Like I open this up all the time. As I was saying, there's over 80 conditions and diseases that they make recommendations on, and that's a lot of things to memorize. It's easier for me. The fun thing is you can go into the app. I think they even showed a picture of it. Let me see if I can pull this up for you guys. Yeah. So if you go into the app here, this is kind of how it opens up. You can put in your specific patient. So let's say you're in clinicals. For those that are students or recently graduated, when you get your new job, you're going to love this. I put in here, I say, yeah, I have a 7-year-old patient. He weighs 180 pounds. He's this tall. It's a male. So no, not pregnant. Yes, they use tobacco. And yes, they're sexually active, and start. It's going to pull me up all the recommendations for that patient based off their weight, based off their age, based off their risk factors like smoking or sexual activity. And it's a really good way for me to go through what is recommended for that specific patient, because these recommendations are patient specific. So that's where it can get a little confusing. So I would definitely recommend to get that app. If anyone has questions about it, you can drop the questions about the app in the chats, or just go ahead and email me, annalise.caffrey@archreview.com. I'm happy to answer anyone's questions. Okay, moving on to types of prevention. I think this is something we kind of need to touch on first before we actually get to screening guidelines, so you guys can start to put into buckets what type of screening and prevention we're doing. So there's really 3 types of prevention. We have primary, secondary, and tertiary. And this may be tickling your guys' brain from nursing school. This is something you learned in nursing school as well. But when I say primary, I want you to think of the first letter P. So P for primary, think prevent. That's the easiest way for me to keep in my brain, because primary and secondary are really the ones I mess up the most. Tertiary is pretty easy because I just remember it's a throwback. So it's how we're trying to get them back to where they started. So someone who's already had a heart attack, when we put them on a medication to help prevent that again or to help get them healthy again, that's a tertiary prevention. Secondary are primary is when it starts to get confusing for me. Primary is anything prevention. So this is before they have a disease. Exercise is a really good way about that. Primary prevention is usually education based. One of the big things we educate patients on is that we should be getting 150 minutes per week of exercise. That would then fall under primary prevention. They don't have any diseases now that we're telling them they need to specifically exercise for. We're trying to prevent future injury, future illness, future disease by exercising early. Wearing a bike helmet, primary prevention. It's not like they already have a brain injury. We're telling them to wear a helmet when biking to remind them that that is a safe way to prevent brain injuries. So primary prevention. Secondary prevention, that's our next category. And when I say secondary, I want you to remember that S, secondary for screenings. So secondary screenings. That's where our USPSTF guidelines come into play. So for example, mammograms, colonoscopies, pap smears, those are all either A or B guidelines that we really should be following as clinicians. And so just remember when you're utilizing primary or secondary prevention, there is no sign or symptom of any condition yet. So if it falls into primary or secondary, you don't have symptoms or a diagnosed condition that you're doing something for. This is just, they don't already have colon cancer and we're doing a colonoscopy to see how far along it is. We're doing the colonoscopy to see if they have colon cancer or polyps. Anything that they already have a symptom, you can immediately move into that tertiary prevention. And remember, that is where we are trying to mitigate and prevent further damage. So, like for example, tertiary, that'd be like if you're working on lowering a client's A1C because they've already been diagnosed with diabetes, tertiary. Physical therapy for someone after a stroke, tertiary. So think and maybe drop in the chat some examples you guys have come up with that you've seen before on test or something to share with your fellow students. But I hope that was kind of a good overview of prevention strategies. Now we're going to get right into our screening guidelines. So let's start with a little pop quiz back on Slido. Who knows what the #1 cancer in the US that caused death was? I want to know if anyone knows the answer to that one. Oh, whoops. Yeah. Let's see, I'm on the wrong. I put it in the wrong spot. Sorry, guys. Okay. Now you guys can answer this question. I gave you a sneak peek at a future question. Okay. Drop it in for me. Bum, ba, da, bum. Colon, lung. I'm seeing a lot of different answers, guys. And if you said lung, you would be correct. That is currently the cancer that leads to the most death in the United States. And actually, colon cancer is on the rise. So I see why you guys said colon cancer. New research that, I mean, I think I was just reading it in my medical journal this month, or maybe last month that came out. In the United States, it is the #1 cause of cancer deaths under 50. So lung cancer is still the most likely to cause death in any age group. So it causes the most deaths, lung cancer does, but colon cancer is the most for men under 50 and the second cause of death for women under 50. So fiber, getting enough fiber, 25 to 35 grams, guys, just so you know, that's my big soapbox. So I'm not going to talk about it today because I'd spend the whole webinar, but it is important to get your fiber in. Okay, back to lung cancer screening. I started with this one because this was one I remember in NP school that I thought was a little weird. I didn't know that we did this as a nurse, and maybe you guys were better nurses than I was, and you did know that this was a recommended screening. But lung cancer screening is something that the USPSTF recommends in all men, in all adults that are 50 to 80 years old that have a 20-year lifetime pack history, and they either quit smoking within the last 15 years or they currently smoke. So that was a lot of words. Just remember this, 50 to 80 years old, that's your age range. And then in order to qualify in that age range, they need to have a 20-year pack history and either currently smoke or have quit smoking in the last 15 years, which is what they consider to be like a recent quitter. Does anyone know how you calculate a smoker's pack history? That one was always kind of a harder one for me in school. Um, so pack history is calculated by multiplying the number of packs, so how many packs they smoke per day, by the number of years they've smoked. So it's just a good way for us to look at the fact that someone who smokes one pack every single day for 15 years, they have a 15-year pack history. But someone who smokes 2 packs per day for 15 years, they're going to have a 30-year pack history. So that's something to look at. So just remember, you have to have a 20-year lifetime pack history. So you can even add, they could say, I mean, I smoked for 10 years, like 3 packs a day. And now for the last 10 years, I've been down to 1 pack per day. So in the last 10 years, their pack history has been 10. And then for that 10 years before, when they were smoking 3 packs per day, that's 30. So you add that up, total 40. So remember, you can do additions if they've been smoking and stopped smoking at different times in their life. And really, it doesn't need to be super exact. It's not like I'm trying to get it down to the months or days. We're just trying to look to see if they qualify. Do they have a 20-year pack history? And if they do, we want to screen them. And screening is done with a low dose CT. So we just put them in a low dose CT, it takes it, and it takes a peek to see if they have lung cancer. Lung cancer is a good one. I think one of the reasons we do this is just because symptoms for this one tend to show up pretty late in cancer. So they'll be pretty far along in the cancer spectrum, staging wise, by the time that they're coming in and saying, yeah, I'm coughing up blood, I can't sleep. And we say, oh man, you may have lung cancer. So the goal here is to catch it really early so we can treat earlier. Yeah, so let's see. I think that is kind of everything for this one. Does anyone have any questions about lung cancer screening? I think that's kind of it. The last thing I wanted to touch on this one was a abdominal aortic aneurysm. So triple A's, the one that presents with like random sharp stabbing pain in the back. There's newer recommendations on this as well. That is kind of funny. It only applies to men because their risk is so much higher than women. But once in their life, men that smoke between the ages of 65 and 75 should be offered an abdominal ultrasound that will just check their abdominal aortic and just check to see if they have any bulging or dilation there that could later lead to an aneurysm. Because a lot of times people have a dilated aorta down here because of their risk factors, and we just monitor and watch it for it to get bigger, and we don't intervene until it gets to a certain size. So just remember, in addition to the lung cancer screening, all men who smoke between the ages of 65 to 75, we offer them a one-time AAA scan with an abdominal ultrasound. So that's kind of everything on that slide. We also want to make sure, though, in addition to this, that we are counseling on smoking cessation. So we want to, use the behavioral change methods, therapy, medications. There's a lot of new medications. This is the kind of conversation that I bring up with my patients every single time I see them, even if I saw them 6 months ago for their hypertension and they told me, no, I'm not interested in quitting right now. I bring it up again 6 months later and I say, hey, John, you still smoking 1 pack a day? Have you thought about quitting? And then if they tell me no, I even always follow that up by saying, what is making you not want to quit? Is it because you just have no interest? Do you understand? Like, I want to make sure that they understand the risks associated with smoking so that the decision to keep smoking is at least educated. Because obviously, in a perfect world, I'd have none of my patients smoke. But if they are going to smoke, I want it to be something that they're doing with an informed risks. So that's a really important one. That's a grade A guideline that you talk to them every single time about stopping smoking. Now jumping over to cervical guidelines, this one can get a little tricky, a little less tricky, I think, if you're a girl and you've been doing this for a couple of years, but we'll go over this together. Does anyone know the highest strains of HPV? There's like two that this is really board testable. They like to ask, what's your highest risk strain of HPV? There's two of them. It's 16 and 18. And I always remember 16 to 18 because I think of the ages like 16 to 18, that's like teen pregnancy central. And so for some reason that just clicked in my brain. Then I just remember, oh yeah, ages 16 to 18, teen pregnancies. That's the most dangerous HPV. So yeah, HPV 16 and HPV 18, they're just different strains. There's a lot of different strains of HPV. You know, there's 6, 11, those cause genital warts, strain 6 and 11, but strain 16 and 18 are what we call high risk HPV. Those are HPVs that often lead to cervical cancer. But the really good news about HPV in general is that we do have a vaccine. It's called Gardasil. It's come out in the last couple, I don't know, probably like the last decade, maybe longer than that at this point. But it's really awesome. It prevents HPV, especially for those individuals that are high risk, meaning they have multiple partners, they're not using protection. Those are going to be those individuals that you consider to be high risk for HPV or high risk for cervical cancer. So Gardasil's actually now been approved for up to 45 years old, and studies do show it dramatically reduces the number of cervical cancers we're having caused by HPV. So really important that we're educating our patients on that vaccination, that prevention, if they are high risk. Otherwise, the other way we test for it, because remember, vaccines are going to be primary prevention. It's preventing a disease, whereas screenings are secondary. So cervical cancer screening, this is a secondary prevention. We're trying to see if they have it and catch it earlier. These are the guidelines. A couple different people put it out. Really, the one you need to know is this top box. The American Cancer Societies is a little bit different, but you don't need to know the difference there. I would say focus on the USPSTF's guidelines, which are you start at age 21. And from age 21 to 29, they get it every 3 years. So every 3 years, they come in for a cytology, which is what we call a pap smear. So they only get that every 3 years. And then once they hit 30 to 65, we screen. We can do the same thing every 3 years. Or they have the option of going every 5 years if they co-test with high risk. That's what HPV, high risk HPV. So that's usually what I recommend my patients do, just because it means they have to get pap smeared less. And if you're a girl and you've ever had a pap smear, you know it's not like the funnest thing ever. I'd way rather be in Disneyland eating a churro than having a pap smear done. So I always recommend once they hit 30, we switch to the 5 years and do the co-testing, the cytology and high risk HPV. And a lot of this is based off of their risk factors. So some people may only need to get the cytology when they're 30 every 3 years because they just say, I'm not really that high risk. I don't care much. But that's kind of what you need to know for cervical cancer screening. The other thing I wanted to make note of here that is really highly tested is that less than 21 years old, we do not recommend pap smears or cervical cancer screening at all, regardless of sexual activity. I could have an 18-year-old come in and tell me that she's having sex 4 times a day with different partners, no protection of any sort, and I'm still not going to recommend cervical cancer screening. We've just decided that the risks at that age are so slim of it being cancerous that it's not worth testing for. So just remember, regardless of sexual activity, less than 21 years old, we do not test. So that's kind of everything for cervical cancer. See, when you break them down like this, they're not that bad, right? Okay. Now we're moving on to breast cancer. And breast cancer guidelines, there's several different sets, a little bit like we saw with cervical cancer that had 2 different sets there. The one you guys really need to know that is tested are going to be USPSTF and ACOG. So these are really, I would say, the 2 biggest. They used to be more different. So it used to be more important because there's more on the next slide here. We'll get into American Cancer Society, the National Comprehensive Cancer Network. So there's a lot of different ones. These are less like the National Comprehensive Cancer Network is the most strict of them. Like they want you to start testing the earliest. You can see they want you to start offering them at age 25, which is great. Like women get breast cancer young. So they're right in saying that if we did mammograms younger, we'd catch cancers that way. But most people have decided that because of the exposure to radiation, because mammograms are an x-ray, we kind of squish the boobs up against a plate and take an x-ray, the risks associated with the radiation actually are more likely to cause cancer than we are likely to catch cancer from doing it earlier. So with that, we kind of stick to these guidelines here. And the US Preventative Task Force used to recommend we start at 50. In the last year or so, they actually have updated their guidelines to match ACOGs better. So they do recommend that we start at age 40. So starting at age 40, kind of regardless of risk factors, we should offer our patients a mammogram every 2 years. After that, of course, the mammograms, how frequently you do it, every 2 years is kind of the general guideline. When you get a mammogram back, the radiologist who read it is going to tell you their recommendation. So some people, for example, will have very fibrous, dense breast tissue. I am very small chested. Unfortunately, I do not have very dense breast tissue. But for some people that do, it's hard to read on the mammogram. So while their risk for cancer is not higher because of it, their risk of missing the cancer during a mammogram is a little bit higher just because they're hard to read. So sometimes you'll get a mammogram back as a provider that says, we recommend they come in 1 year. So just read it and base your guidelines, how frequently you're doing from a clinic standpoint off of that. For a test, just know that it is recommended every 2 years. At age 75, that is when we discontinue the guidelines. So I always tell women when they come in and they're older, especially since I love the geriatric population, I'm like, there are some benefits getting older. You don't need a pap smear anymore after 65. After 75, we can discontinue mammograms. Some insurances will let you continue mammograms after 75. I have a couple patients I'm currently seeing that are still getting mammograms in their 80s because they're very high risk and their quality of life is super high and they want to keep getting them. Usually it's a little bit of a fight with insurance to get that, but for the most part, they won't put up too much of a fight. Okay, moving on to colon cancer. And like we were saying, guys, earlier with the colon cancer deaths, this is the second cause of death in the US from cancer is colon. And I would say that is currently on the rise. I would guess that it's not too much longer because of how much we emphasize smoking cessation, that lung cancer goes down and colon cancer comes up because of our poor diet. So maybe if you see me giving this webinar in a couple years, that information will have changed. So real quick pop quiz here for you guys. What age do we start colon cancer screening? Let's see. I know you guys saw this one earlier. I cheated a little bit. Let's see. Bum, bum, bum. We see 45, 40 based on risk. I love that. This is the cop-out answer. That is so me. Based on risk, 55. 50. This is a harder question because the guideline 60. The guidelines have changed a lot in the past couple years because, as we said, colon cancer is on the rise. But as of right now, because colon cancer is the second leading cause of death, we have dropped the age again from 50 down to 45. So those of you that had 45, you were right. It is earlier based on risk factor. So if I have a patient come in who's 40 and his mom and dad both died of colon cancer, since there is a family history link there, I would start him at 40. So the guidelines are usually about 5 or 10 years before the age of the family member that got colon cancer. So let's say his dad got colon cancer at 45. Usually the recommendation would be to start between 35 and 40. So 5 to 10 years before the age his dad was diagnosed. Does that make sense? So there are two main pathways that we screen for colon cancer. Colonoscopy is the gold standard because it's going to be the best. We're literally sticking a camera up there and we're getting a good look. But also it is more expensive. It is invasive. You have to do bowel prep. And they are sedated with anesthesia. So now they have to have someone drive them home from their appointment. So it is just a lot more complicated than some of the other options like fecal sample tests. My dad how old is my dad? He's born in 67. So he is, what does that make him, guys? 357? I think he is 57, right? He just had his birthday in April. I should know this. Anyway, he just got his first colonoscopy last year. And I am a APRN with a doctorate. I was writing him so hard. You guys wouldn't believe it. I was like, Dad, you have to get a colonoscopy. Colon cancer is the number 2 cancer causing death in the United States. You need to get a colonoscopy. You need to get a colonoscopy. My mom got it when she turned 45, like she was supposed to. My dad just did not want to do the bowel prep. He was throwing such a fit about it. And we went in and we got him his colonoscopy and he had a polyp. So polyps are precancerous spots that they kind of clip out. They're not always precancerous, but usually if you find any polyps, they recommend you come back in 5 years rather than 10. And so he was actually really glad that in the end he went and did it. So sometimes we have to advocate not only just for our patients, but for our own family members that don't want to get their tests done. So yes, like I was saying, we usually rescreen colonoscopies 5 to 10 years. That's what I would remember. They get a colonoscopy, they only have to come back every 5 to 10 years. On the flip side, we have that at-home screening kits, like they're called FIT tests, fecal sample tests, where they mail in a piece of their poop, and they can screen that way. The issue with this test, I will give a couple caveats for it because everyone's like, why would I get a colonoscopy if I could just mail in a piece of my poop? Caveats to it. It really only should be used on lower risk individuals. So individuals that have never had polyps, that have no family or personal history of colon cancer, and it has to be redone every single year. So that's the kind of test that you do pretty much every single year. There's a couple of them out there on the market that they say do every 3 years, but for the most part, it is kind of a yearly test, and that just makes it not very fun. Moving on to bone density screening. This is our last big screening we're going to cover today, guys. Density screening guidelines are near and dear to my heart because bone density screening detects osteoporosis, osteopenia, and it also helps us stage how far along the issue is. Whoa, whoopsie. Sorry, guys, I just lost my screen. There we go. So really important that we're doing this. With bone density screening, or you guys may have heard it called a DEXA scan, because that is really the name of the gold standard scan for bone density. We start that at age 65 in women. So all women 65 and older get screened about every 2 years. They get a DEXA scan done. And what that does, it's kind of like, DEXA stands for dual energy X-ray absorptiometry or something. I can't pronounce well because I only ever call it DEXA scan. It's kind of like taking a bunch of x-rays. It looks at how dense your bones are. So it will scan them. It's a pretty easy test. My mom just got hers. They had her do hers just because she has a really high family history of osteoporosis. And she said, she's like, it was weird. I just like stood up like I was getting like a tan or something, like a spray tan. Just have you stand weird, a couple different positions, and it just checks for your bone density. So with bone density screening, remember we do it for women 65 and older every 1 to 2 years based off what their results are. The other people that can get it are men over the age of 70 is another recommended group that have risk factors. So while like AAA screening was for men only, bone density screening is really for women only. This is a kind of screening you're only going to be seen done on women unless you have a male patient 70 or older who has a lot of risk factors. So let's say strong family history of osteoporosis, they are a vegan, and so we know that their B12 is really low, and let's say they don't eat they don't do any weight-bearing exercise. So they're a big swimmer, they don't walk, they don't run, they don't do any weightlifting or strength training. I'd say yeah, they're higher risk. It may be worth getting a DEXA scan on them. But for the most part, what you need to know is 65 and older every 1 to 2 years. What the DEXA scan is going to do is it gives a fracture risk a score. So that's called a FRAX. So they look at all of these things and you're going to get two things back from a DEXA scan. You're going to get a T score that's going to tell you that's how we decide whether they have normal bone density, osteopenia, or osteoporosis. Osteopenia is that -1 to -2.4 on a T score. That's when we say, okay, their bones are kind of holy, but it's not too bad yet. That's when we're going to do like calcium, vitamin D supplementation. And then you have -2.5 and less, which is when we start to get into osteoporosis. The next thing a DEXA scan is going to assign to us is that FRAX score. And a FRAX score is a fracture risk assessment tool. And what it looks at is it looks at not only just what their T score was, but it takes their T score. It also looks at their age, their sex, weight, height, if they've had previous fractures, their family history, what their smoking status is, if they've ever used steroids before, if they use alcohol more than 3 times a day. So it looks at all this stuff. And normally it takes the T score at your hip, because that's like one of our densest bones, and it assigns a percent. So what it looks at is your risk of having a fracture A pathological fracture where it's just like your bone breaks doing something that it normally wouldn't because it's so holy in 10 years. So if there's a percentage of 3 or greater for a hip fracture, that is considered pretty high risk. And that's when we start people on bisphosphates, like Fosamax, for example. That's kind of what we're looking at. That means they have a major risk of an osteoporotic fracture. Okay, that is kind of everything there. I know I talked about that we start with conservative measures, especially if they have osteopenia and not like a super strong family history. That's when we start with weight-bearing exercises like walking, running, weightlifting, and then vitamin D and calcium supplementation. When you start to get into that 2.5 and lower, you really are having a pretty holy bone that starts to get dangerous, and we need to attempt to remineralize it with things like bisphosphates. But remember, bisphosphates, if you guys have taken farm yet, they have a lot of side effects, especially that irritated esophagus. So we try, a lot of patients won't be able to tolerate those, and we may need to do like IV infusions of vitamin D or calcium for those patients. Okay. That is it for bone density. Now I've got a practice question for you guys real quick before we end. So, practice question here. Mrs. Jones is a 73-year-old. She has a FRAX score of 10%, hip fracture at 4% over the next 10 years. T-score is negative 2.8. So remember, negative 2.8, what does that mean? Is that osteopenia, osteoporosis? What are you guys thinking in your heads? Start working through it that way. The nurse practitioner decides to prescribe alendronate, Fosamax, weekly. What statement made by the patient indicates a need for further teaching? So let's hop over here into Slido, and you guys can answer this question. What is your patient going to say that you're going to say, you know what, that's not right? They've got the wrong answer. They've got the wrong idea about this medication and they need further teaching. It wasn't on the slide, but it was something I mentioned out loud. Okay, guys, getting some answers put in. Okay, so it looks like the two big answers right now that have taken the lead are, I will plan to take my medication at bedtime to reduce the chance of nausea, and I will plan to take my medication on an empty stomach with a full glass of water. So I will tell you guys now the right answer is C, meaning that's the wrong answer from the patient. Fosamax is always taken on an empty stomach first thing in the morning with that full glass of water because it is so irritating to the esophagus and the stomach. We want to try to kind of wash it down as much as possible. They also then have to sit upright for 30 minutes after taking that medication. So they take it once weekly. They take it on an empty stomach in the morning, full glass of water, and then they have to sit upright. If you take it at bedtime because they're going to then go lay down, that is going to make them pretty sick and it's going to irritate that esophagus. So that is why we never do that one. So I'm back over here to this. There is your answer. Okay, now just last couple of things here in Slido, if you guys stay in there. I want to see, are you guys feeling a little bit more confident about some of these screening guidelines? How are you feeling now compared to how we were feeling at the start of this thing? I want to know if I did an okay job today. Feeling a little bit better. Okay, this is good, guys. This is what I want for you guys. If this is still a subject you guys are struggling with, if any of this was confusing to you guys and you want some more help, let me know. You can always email me. Oh, my slide, I think about, in fact, I'm missing a slide now that, oh, here we go. I accidentally skipped it for breast cancer screening. Let me hop back over to this so you guys have my email. This slide just kind of goes over all the stuff we talk about. I got so into the screening guidelines that I got distracted. But Archer Review NP program is growing exponentially. We are just really taking off. We have amazing pass rates. We offer 3-day live reviews on demand. We have a question bank with over 1,600 questions. We just put out some clinical skill videos that I filmed professionally to kind of show you guys things like suturing, some of those musculoskeletal assessments that get hard and confusing. You can join us here if you scan this link. That's going to take you to our social page. So our Instagram, Facebook, TikTok are groups that we offer. We have a Facebook group that I post questions in every single day just to practice for you guys that are studying for your boards, just daily practice questions. And then lastly, over here, this is my email down here, nursepractitioner@archreview.com. If you email that, screenshot it, email me at any time about questions you have, help you need. We do private tutoring if you feel like you need more of a one-on-one where you can ask me questions in real time and I can respond to them. So a lot of options for you guys. Obviously, our goal overarching as Archer is to be really affordable and to give you guys really good content. I want everyone to pass their boards. I do not want that to be a barrier to you guys being able to practice, to get a job, to be a clinician, because in all honesty, guys, if you graduated school, you know the content you need to know, you're going to be a good provider. Grad school is really hard, and I'm proud of you guys for chugging along. You're going to be great. I just want to end now, give you guys a chance to ask any questions. We just have a few more minutes, so if you have a question, spit it in there real quick. I will answer it. It doesn't have to be about screening guidelines. And then also just if you have any webinars you'd like to see more of in the future, so you can answer either of those on these one right now, and I'll just jot down those responses. If there's something you're like, Annie, I'm begging, please make a webinar on diabetes treatment. I just want to know only about diabetes treatments. That's it. So put an answer in if you have anything. Oh, thank you. I'm glad they're helpful. I always get a little nervous before I get on a webinar. And so that makes me nervous. I'm glad to know it was helpful to you guys. Okay, you guys want a 3-day live review sooner rather than later. Okay, I will mark that one down. And see what we can do to get that rescheduled for you guys studying. If you are taking your board soon and that's something you're stressing about, send me an email and I will get you over the recording of a previous 3-day live review. I mean, the content's the same and you can watch that so that at least we can make sure. I mean, obviously our goal at Archer is for you to pass your boards. So if there's not a 3-day live review that works on the calendar for you right now, I want you to have a recording of it. So do not hesitate to reach out. One more question here. Brittany's Big 3 lecture again. Okay, I'll write that one down. Yeah, we haven't given that one in a little bit. Awesome. How does taking glucocorticoid steroids cause osteoporosis? That is a great question. So sorry, I'm trying to let people know I just need a few more minutes on this webinar so I can answer your question. Steroids cause osteoporosis because they cause bone loss. And that's through a couple different mechanisms. The big one, if I remember correctly, is going to be osteoblast activity. So glucocorticoids, they suppress the cells that build bone. So those are osteoblasts. Those build bone. So blasts build bone. They suppress that. And then they also increase osteoclast, which is what causes bone reabsorption or bone loss. So they're just a really hard drug because they have those really two big activities that cause bone loss. It's going to cause your bones to be more holy, especially the longer they're on them. So, I mean, someone who takes it just for a week or something because they've got shingles, I'm not worried about bone loss. This is going to be people that have chronic issues that they're on a chronic steroid for. They're going to be the ones whose bone formation has been decreased for a long time and bone reabsorption has been increased for a long time. So those are all kind of things. I hope that answered that question. Okay, guys, we're going to go ahead and end here. Thank you so much for joining today. This was really, really wonderful. I love going back over screening guidelines. I told you guys screening guidelines are my bread and butter. I think that it's something we need to be doing at every single visit more frequently. And I'll just leave it up here again, my email, in case you guys have any questions. I want you guys to feel like you can reach out to us at any time. We're not AI, we're live people, live nurse practitioners. Most of us still work in a clinic. So just trying to get you guys the best information out there so that you all pass and feel confident being a good provider. So thank you for joining, and I will see you guys at our next webinar.